This is Winter 2023 Con Ed PowerPoint presentation, pre-work on lab values for HopCom. Disclaimer. This information does not reflect HopCom dispatch or triage processes or indicate any changes in our current workflow. The contents of this presentation are for personal enrichment only. Please feel free to contact your educator with any questions. Objectives. Number 1, why are labs ordered? Well, multiple reasons. For diagnosis, to help rule in or rule out a diagnosis for a patient. Screening, for congenital hypothyroidism via, for instance, neonatal thyroxine testing. Monitoring, to, for instance, see the effect of drug therapy. And research, to understand the pathophysiology of a particular disease process. Number 2, how do lab results relate to keeping the body in balance? Well, if lab results are normal, then the balance in the body is good. If lab results are abnormal, diagnosis and treatment of different conditions can be guided by said results. Number 3, how are these results categorized and documented? Well, they're grouped in many different types. There's chemistry panels, hematology counts, clotting factors, to name a few. You'll see more with the upcoming slides. In electronic records, lab results are listed and they're noted if the values are abnormal. In quick shorthand, some clinicians use Fishbones for quick reference. Number 4, how do lab results apply to our practice? They help guide our treatment plan for patients based on different results. And what do you do with lab results for number 5? When triaging different categories of patients, knowing which labs to ask for that may direct care for a patient can be important. What are lab values? Materials in blood that we can measure in a lab and compare to scientifically accepted standards to help assess a patient's condition. The rest of blood is plasma, which is mostly water, and is the fluid in the flow of blood that carries everything throughout the body. Cells, hormones, biological waste or byproducts, electrolytes, enzymes, gases, proteins, and sugar. Lab values equal percentages and amounts, measurements to help aid in diagnosis and treatment of different conditions. They can be drawn from an arterial source, a venous source, or from a capillary source as well. Slide number 5, homeostasis. Homeostasis equals stability, balance, or equilibrium within a cell or the body. The endocrine system plays an important role in the body's homeostasis. It helps to maintain internally stable conditions, such as body temperature, blood glucose level, and osmolarity, in spite of change in the person's or organism's environment. Most common lab values in fishbone diagram form. You have your CBC or heme8, which is a complete blood count. You have your CMP or BMP for your metabolic panels. You have liver enzymes, acid base, which can be for arterial blood gas or venous blood gas, coagulation studies, and then other ones that show cardiac markers or other labs for specific disease processes. Figure number 5, the CBC or heme8, counts the number of cells that make up the different parts of your blood. With a differential, they can detect abnormal or immature cells. They can also help diagnose an infection, inflammation, leukemia, or an immune system disorder. Figure number 4 is your basic metabolic panel, or BMP, that provides information on your blood sugar, the balance of electrolytes and fluids, and the health of your kidneys. It gives a general metabolism overview. The CMP shows the current status of your metabolism, the health of the kidneys, liver, electrolyte and acid-base balance, as well as levels of blood glucose and blood proteins. They're recommended specifically for concerns about the liver, so it is your BMP plus liver labs and other electrolytes. So that's figure 4, figure 1, and figure number 2. Figure number 3 is your arterial blood gas for the acid-base balance. It measures the acidity or the pH and the levels of oxygen and carbon dioxide in the blood from your artery. It's used to check how well your lungs are able to move oxygen into the blood and remove carbon dioxide from the blood. Figure number 6 is coagulation studies. It measures your blood's ability to clot and how long it takes to clot. The kidneys and lungs maintain the balance or proper pH level of chemicals called acids and bases in the body. Acidosis is abnormally high level of acidity or low level of alkalinity in the body fluids, including the blood. The two primary types are respiratory and metabolic. Overproduction of acid that builds up in the blood or an excessive loss of bicarbonate from the blood is metabolic acidosis. A buildup of CO2 in the blood that results from poor lung function or depressed breathing is respiratory acidosis. Some common causes of acidosis are GI bicarb loss, renal tubular necrosis, drug-induced hyperkalemia, early renal failure, or administration of acids. Hypoxia is a condition in which the body or a region of the body is deprived of adequate oxygen supply at the tissue level. Classifications are generalized or whole body, or local, where just a region of the body is affected. There are 4 types: hypoxic hypoxia, hypemic hypoxia, stagnant hypoxia, and histotoxic hypoxia. Some common causes include heart conditions, including defects, or lung conditions such as asthma, emphysema, and bronchitis. Hypercapnia is excessive CO2 in the bloodstream, typically caused by inadequate respirations. Some common causes of hypercapnia include hypoventilation, lung diseases, so COPD or OSA, or diminished consciousness, exposure to environments with abnormally high concentrations of CO2, or rebreathing exhaled CO2. Alkalosis is an abnormally low level of acidity or high level of alkalinity in the body fluids, including the blood. The two primary types are respiratory and metabolic. An overabundance of bicarb in the blood, or loss of acid from the blood, is metabolic alkalosis. A low level of CO2 in the blood that results from rapid or deep breathing is respiratory alkalosis. Some common causes of alkalosis are hormonal and metabolic disorders. A VQ mismatch, or a mismatch between ventilation and perfusion, happens when part of your lung receives oxygen without blood flow or blood flow without oxygen. Some examples include obstructed airway, so choking or a mass, or an obstructed blood vessel, such as a PE in the lung. The pH scale shows the power of the hydrogen ion. It is a measure of the negative log of hydrogen ion concentration, which is scientific notation or shorthand that means the lower the pH, the higher the hydrogen ion concentration and the more acidic. Conversely, the higher the pH, the lesser the hydrogen ion concentration and the more alkalotic. Hydrogen ion increases or decreases 10 times for every whole number on the pH scale. So, a pH of 6 has 10 times higher hydrogen ions than a pH of 7. Sterile water is neutral at 7.0, and blood is on the alkaline side of the scale. ABGs. ABGs are drawn from arteries to sample blood that is carrying O2 from the lungs. If the pH is low, then it's acidic. If it's high, then it's alkalotic. ABG is continued. There's different components of the ABG. The first is the pH. Normal pH is 7.35 to 7.45. The second is your PaCO2, or your partial pressure of carbon dioxide. It specifically evaluates the CO2 levels in the blood. If you have high levels of CO2, think of it as an acid, so acidosis for the patient. Normal is 35 to 45. If it's high, you have hypercapnia, and that can lead to respiratory failure. Common causes are COPD, or an obstructive lung disease, severe vomiting, overuse of diuretics, or aldosteronism, which causes high blood pressure. If it's low, or hypocapnia, it can lead to alkalosis. Some common causes of that are kidney dysfunction or failure, severe diarrhea, anorexia or starvation, overuse of hydrochlorothiazide diuretics used to reduce stroke and heart attack risk, and diabetic acidosis. Third component is your PaO2, or your partial pressure of oxygen. It specifically evaluates oxygen levels in the blood, the plasma, and reflects how well oxygen is able to move from the lungs to the blood. A normal reading is 75 to 100. It's used to assess the effects of breathing problems on oxygen supply, especially during an episode of severe respiratory distress. If it's high, you can decrease the oxygen. If it's low, you need to increase the oxygen. The fourth number is your bicarbonate, or your HCO3. It helps maintain the body's acid and base balance and plays an important role in moving carbon dioxide through the bloodstream. A normal value for that is 22 to 26. The fifth value is your SpO2. That indicates the oxygen bound to the hemoglobin, or your pulse ox. It's externally measured and it's expressed in a percentage. The SaO2 is indicated oxygen bound to the hemoglobin. That's internally measured and it's expressed in percentage as well. Next, we're going to be looking at the CBC, or figure number 5 on these fishbone diagrams. ABG is continued. There's different components of the ABG. The first is the pH. Normal pH is 7.35 to 7.45. The second is your PaCO2, or your partial pressure of carbon dioxide. It specifically evaluates the CO2 levels in the blood. If you have high levels of CO2, think of it as an acid, so acidosis for the patient. Normal is 35 to 45. If it's high, you have hypercapnia, and that can lead to respiratory failure. Common causes are COPD, or an obstructive lung disease, severe vomiting, overuse of diuretics, or aldosteronism, which causes high blood pressure. If it's low, or hypocapnia, it can lead to alkalosis. Some common causes of that are kidney dysfunction or failure, severe diarrhea, anorexia or starvation, overuse of hydrochlorothiazide diuretics used to reduce stroke and heart attack risk, and diabetic acidosis. Third component is your PaO2, or your partial pressure of oxygen. It specifically evaluates oxygen levels in the blood, the plasma, and reflects how well oxygen is able to move from the lungs to the blood. A normal reading is 75 to 100. It's used to assess the effects of breathing problems on oxygen supply, especially during an episode of severe respiratory distress. If it's high, you can decrease the oxygen. If it's low, you need to increase the oxygen. The fourth number is your bicarbonate, or your HCO3. It helps maintain the body's acid and base balance and plays an important role in moving carbon dioxide through the bloodstream. A normal value for that is 22 to 26. The fifth value is your SpO2. That indicates the oxygen bound to the hemoglobin, or your pulse ox. It's externally measured and it's expressed in a percentage. The SaO2 is indicated oxygen bound to the hemoglobin. That's internally measured and it's expressed in percentage as well. The kidneys and lungs maintain the balance or proper pH level of chemicals called acids and bases in the body. Acidosis is abnormally high level of acidity or low level of alkalinity in the body fluids, including the blood. The two primary types are respiratory and metabolic. Overproduction of acid that builds up in the blood or an excessive loss of bicarbonate from the blood is metabolic acidosis. A buildup of CO2 in the blood that results from poor lung function or depressed breathing is respiratory acidosis. Some common causes of acidosis are GI bicarb loss, renal tubular necrosis, drug-induced hyperkalemia, early renal failure, or administration of acids. Hypoxia is a condition in which the body or a region of the body is deprived of adequate oxygen supply at the tissue level. Classifications are generalized or whole body, or local, where just a region of the body is affected. There are 4 types: hypoxic hypoxia, hypemic hypoxia, stagnant hypoxia, and histotoxic hypoxia. Some common causes include heart conditions, including defects, or lung conditions such as asthma, emphysema, and bronchitis. Hypercapnia is excessive CO2 in the bloodstream, typically caused by inadequate respirations. Some common causes of hypercapnia include hypoventilation, lung diseases, so COPD or OSA, or diminished consciousness, exposure to environments with abnormally high concentrations of CO2, or rebreathing exhaled CO2. Alkalosis is an abnormally low level of acidity or high level of alkalinity in the body fluids, including the blood. The two primary types are respiratory and metabolic. An overabundance of bicarb in the blood, or loss of acid from the blood, is metabolic alkalosis. A low level of CO2 in the blood that results from rapid or deep breathing is respiratory alkalosis. Some common causes of alkalosis are hormonal and metabolic disorders. A VQ mismatch, or a mismatch between ventilation and perfusion, happens when part of your lung receives oxygen without blood flow, or blood flow without oxygen. Some examples include obstructed airway, so choking or a mass, or an obstructed blood vessel, such as a PE in the lung. WBCs, or white blood cells, otherwise known as leukocytes, are derived from the Greek word for white, which is leuko. They are your body's immune response soldiers, and they're made in the bone marrow. There are 5 different types. The first is neutrophils. They make up 40 to 60% of your WBCs. They help stop microorganisms and infections by eating them and destroying them with enzymes. So they kill and digest bacteria and fungi. They're your most numerous type and your first line of defense. The second type is lymphocytes. They're 20 to 40% of your WBC count. They use antibodies to stop bacteria or viruses from entering the body, B-cell lymphocytes, and they kill off the body cells if they've been compromised by a virus, or cancer cells, T-cell lymphocytes. So they create antibodies. Monocytes is the third type of WBC. They make up 2 to 8%. They become a macrophage in the body's tissues, eating microorganisms and getting rid of dead cells while increasing your immune system strength. So they help break down bacteria. Eosinophils are the fourth type. They make up 1 to 4% of your WBC count. They help control inflammation, especially active during parasite infections and allergic reactions. And they stop substances or other foreign materials from harming the body. They attack and kill parasites and cancer cells and help with the allergic response in the body. Basophils are the fifth type, coming in at 0.5 to 1% of your WBC count. They produce enzymes or chemicals such as histamines during asthma attacks and allergic reactions. They are the alarm system that kicks off your body's immune response. Platelets bond together when they recognize damaged blood vessels and help build clots. Their jagged, random shape makes them good at locking into gaps and creating a structure on which blood can clot. Thrombocytopenia is a condition where you do not have enough platelets. There's a wide range of causes, including medications, inherited conditions, certain types of cancer, kidney infection or dysfunction, or too much alcohol. Your platelet count drops when something is preventing your body from producing platelets. Symptoms can include easy bruising, frequent bleeding from mucosal areas like your gums, your nose, or GI tract. Thrombocytosis is a condition of too many platelets. There's 2 main types, abnormal or essential, where there's abnormal cells in the bone marrow causing an increase in platelets. The reason is unknown. Secondary thrombocytosis is the same condition as primary, too many platelets, but it can be caused by ongoing conditions such as diseases, anemia, cancer, inflammation, or an infection. Puts you at an increased risk for clotting. Symptoms include spontaneous blood clots in your arms and legs, and if untreated, they can lead to heart attack and stroke. Is your fishbone diagrams again. We're going to be looking further into figure 4, your BMP or basic metabolic panel, and figures 1 and 2, your comprehensive metabolic panel or the CMP. Here are your BMP and CMP fishbones with the normal values in the diagrams below. What is the comprehensive metabolic panel? To start, the basic metabolic panel, or the BMP, provides information on your blood sugar or glucose level, the balance of electrolytes and fluids, and the health of your kidneys. It gives a general metabolism overview and shows concerns that are present about your kidneys or your blood glucose levels. The CMP takes it a step further, or the comprehensive metabolic panel, and shows the current status of your metabolism, the health of your kidneys, your liver, electrolytes, and acid-base balance, as well as levels of blood glucose and blood proteins. It's recommended specifically for concerns about the liver, so they would ask for a BMP plus liver labs and other electrolytes. Electrolytes. Electrolytes are going to be present on all of your metabolic panels. Sodium is a major cation or positive ion outside of your cells. Primarily helps control the amount of fluid in the body. It helps your nerves and muscles to work properly and is the lab we look at a lot for neuro. High sodium or hypernatremia can cause fatigue, irritability, restlessness, headache, nausea, vomiting, confusion, seizures, and coma. Hyponatremia, or low sodium, can cause nausea, vomiting, abdominal cramping, lethargy, headache, respiratory arrest, and coma. Potassium is the major cation or positive ion inside of your cells, and it helps the heart and muscles to work properly, primarily affecting the muscles that are smooth and cardiac. Hyperkalemia, or high potassium, causes progressive muscle weakness leading to paralysis. In your heart, that means bradycardia, heart block, or asystole, and can lead to EKG changes. Hypokalemia, or low potassium, causes spastic paralysis, constipation, and ileus or blockage. Polyuria, or excessive urination, or polydipsia, which is excessive thirst, can also cause EKG changes. Chloride helps control the amount of fluid in the body and to maintain healthy blood volume and blood pressure. Bicarbonate or carbon dioxide helps maintain the body's acid-base balance and plays an important role in moving carbon dioxide through the bloodstream. It shows as a carbon dioxide in the fishbone sometimes. Electrolytes continued. Magnesium is the fourth most abundant mineral in the body. It regulates the body's nerves and muscles and is critical for normal metabolism and function of an organism. It is the yin to calcium's yang for muscle movement, acting as a natural calcium blocker to help muscles relax. It also plays a role in protein synthesis. Calcium is the most abundant electrolyte in the body. Aside from bone and teeth structures, it's used for muscle contraction, nerve impulses, and hormone and enzyme release. Glucose is the type of sugar that is the body's main source of energy. Insulin helps move glucose from the bloodstream into the cells. Byproducts. BUN, or blood urea nitrogen, is a waste product of protein metabolism. Urea is formed by the liver and carried to the kidneys for excretion. Because urea is cleared from the bloodstream by the kidneys, a test measuring how much nitrogen remains in the blood can be used to test renal function. Elevated BUN, or azotemia, is associated with kidney failure and malnutrition. Creatinine is a byproduct of muscle degradation. It can be used as an evaluator of kidney function. Elevated creatinine indicates decreased kidney function, meaning the kidneys are not clearing waste efficiently. Lactate measures the level of lactic acid made in the body. This is mostly made by muscle tissue and red blood cells. When oxygen levels in the body are normal, carbs break down into water and carbon dioxide. When oxygen levels in the body are low, carbs break down energy and make lactic acid. Levels also get higher when strenuous exercise is happening or other conditions. These include heart failure, severe infection or sepsis, or shock. These lower the flow of blood and oxygen throughout the body. Or your lactic acid level can increase when your liver is severely damaged or diseased, because that's where the lactic acid is normally broken down. Now we are going to look at the proteins and liver enzymes as indicated by these fishbones. Proteins and liver enzymes are tests mainly done to diagnose liver disease and monitor liver function. AST, or aspartate aminotransferase, is an enzyme found in high amounts in the liver, heart, and muscle cells. This test is mainly done along with other tests such as ALT, ALK-Phos, and bilirubin to diagnose and monitor liver disease. ALT, or alanine aminotransferase, is an enzyme found in highest amounts in the liver. Injury of the liver results in release of this substance into the blood, and it's used to determine if the patient has liver damage. ALK-Phos, or alkaline phosphatase, is a protein found in all body tissues, notably in the bile duct epithelial cells. Biliary stasis can lead to release of this enzyme. It's an enzyme that transports metabolites across cell membranes. Tissues with higher amounts of ALK-Phos include the liver, bile ducts, and bone. This test is used to diagnose liver or bone disease. T-bili, or total bilirubin, is a catabolic product of hemoglobin, which is released in the unconjugated form and conjugated to a water-soluble product by hepatic cells. Elevated levels indicate liver damage or disease. Albumin is the main protein of human plasma. It helps keep fluid in your bloodstream so it does not leak into other tissues. It also carries various substances throughout the body, including hormones, vitamins, and enzymes. Low albumin levels can indicate issues with the liver or kidneys. We will now be looking at Figure 6 on the fishbone diagrams for coagulation studies. Coagulation studies, or coags, include PT, prothrombin time, PTT, partial thromboplastin time, and INR, international normalized ratio. Coagulation studies, or coags, include 3 different lab results. The first is PT, or prothrombin time. This evaluates the body's ability to clot. The next is INR, or international normalized ratio. This ensures that the results from a PT test are the same from one lab to another. PTT, or partial thromboplastin time, determines if blood-thinning therapies are effective. It has an assay of the extrinsic pathway of coagulation, and it also assesses factors 1, 2, 5, 7, and 10 out of the 12 vital blood clotting factors. For cardiac labs, we'll be discussing some hormones and proteins. The normal values provided on this slide are for BNP, CK, troponin, high sensitivity troponin, and CKMB. BNP, or brain natriuretic peptide, is a hormone produced by the ventricles that increases in response to ventricular expansion and pressure overload. It is an indicator of CHF, or congestive heart failure. The higher the BNP, the worse the CHF. Creatine kinase, or CK, is an enzyme found primarily in muscle and heart tissue and the brain. Elevated CK levels that are not caused by strenuous exercise or intramuscular injections may indicate muscle disease, i.e. muscular dystrophy, heart attack, or stroke. Troponin is a group of proteins found in skeletal and cardiac muscle fibers that regulate muscular contraction. Elevated levels can indicate ACS or MI, acute coronary syndrome, or myocardial infarction, and you would usually get trends to see when it peaks. Elevated levels can be caused from non-cardiac issues as well. For example, PE or pulmonary embolism, ARDS, sepsis, CVA, a stroke, diabetes, rhabdomyolysis, burns, etc. Myoglobin is a protein found in muscles that stores oxygen. It provides oxygen to working muscles. Elevated myoglobin indicates muscle damage but does not show where damage took place. It can be used as an indicator for an MI or myocardial infarction. This slide includes some labs of interest in helping to diagnose patients with COVID-19. D-dimer is a protein fragment that is made when a blood clot dissolves in the body. It is used to help rule out the presence of an inappropriate blood clot or thrombus, such as a DVT or deep vein thrombosis, or PE, pulmonary embolism. Procalcitonin is the peptide precursor of the hormone calcitonin, which is involved in calcium homeostasis. It is produced by many types of cells in the body, often in response to bacterial infections, but also in response to tissue injury. The level in the blood can increase significantly in systemic bacterial infections and sepsis. Evidence shows it is a valuable tool in identifying COVID-19 patients who may be at risk for bacterial co-infection. C-reactive protein, or CRP, is a test that measures the level of C-reactive protein in the blood. It is a protein made by the liver that increases when there is a condition causing inflammation somewhere in the body due to acute conditions or to monitor the severity of disease in chronic conditions. Labs for triage. After determination of clinical category for triage and receiving a brief patient history, you may request any labs that may be pertinent or abnormal if the referring facility was able to obtain them. Pertinent labs to ask for when triaging an OB patient, if available: hemoglobin and hematocrit, or H&H, platelets, coags, glucose or BMP, and type and screen. This slide has a chart with selected maternal and maternal newborn laboratory values, meaning values pre-pregnancy and values during pregnancy. Questions to ask when triaging a neuro patient. You'll want to get a brief, focused patient history, including their last known normal. That is needed to clearly define onset of stroke symptoms. You'll also want to note the presence of any medical conditions associated with coagulation disorders, including alcoholism, renal or liver failure, or drug abuse. Neurotriage continued for a patient with a stroke or brain bleed. You need to determine if they're a candidate for alteplase or TPA. This is contraindicated when they have a known coagulopathy or when a patient is taking Coumadin or warfarin with an INR of greater than 1.7 and elevated PTT or platelets greater than 100,000. Alteplase or TPA should be administered to all eligible acute stroke patients within 3 hours of last known normal and to a more selective group of eligible acute stroke patients within 4.5 hours of last known normal. Important labs to ask for are coags, including PT, INR, and PTT, hemoglobin and hematocrit, platelet count, sodium and potassium, as well as glucose. Neurotriage continued. Mechanical thrombectomy is best for large vessel occlusions, or LVO. It should be considered if a patient is out of the time window for anticoagulation with alteplase or TPA. Should be performed within 6 to 24 hours of a patient's last known normal, with an NIH stroke scale score of greater than or equal to 6 on a patient that's greater than 18 years old. Mechanical thrombectomy is contraindicated for a patient with an intracranial hemorrhage, small vessel occlusion, coagulopathies that cannot be corrected, and an elevated blood pressure that cannot be corrected, a systolic of greater than 185 or a diastolic of greater than 110. Again, Labs to ask for in a neuro patient are coags, including PT, INR, and PTT, hemoglobin and hematocrit, platelets, sodium and potassium, as well as glucose. Slide 36. Labs to ask for when triaging a neuro patient and what they are. Sodium, a normal value would be 135 to 145. Coags, including PT, that's the seconds required to clot, the INR, which is the ratio using a PT result, and a PTT, which measures effectiveness of blood thinners. You'll also want to get platelets, which is a measurement of the number of platelets in a sample, hemoglobin and hematocrit, a glucose, and an end-tidal CO2 if available. Lifeline's implementation of the Just Say Yes program involves 4 different steps: activation, deployment, arrival, and transition. Activation. First, referral has to be accepted by JHH Neurosurgery and the NCCU, and a need identified for Lifeline. Next, HAL is to contact HOPCOM and request clinical lead for activation. The clinical lead is then connected via HAL with the JHH stroke attending or neurosurgery to discuss referring facility where the patient is currently located, brief clinical, and expected plan. Lastly, Lifeline clinical lead will confirm Lifeline availability, meaning team availability, when their ETA would be, and a confirmation of plan and destination. Deployment. HOPCOM to alert air or ground team as appropriate. HOPCOM will then complete clinical triage for Lifeline clinical team. The Lifeline clinical team will receive an alert from HOPCOM that includes the referring facility, the diagnosis and brief clinical information, as well as the intended destination for the patient if known. HOPCOM will then conference in the Lifeline clinical lead with the NCCU charge nurse to discuss details. This will include the plan for patient arrival, confirmation of the bed or room number for the patient, and an ETA for when Lifeline should get to the NCCU with the patient. Lifeline clinical lead will then speak with the Lifeline clinical team to convey details. If the patient will require imaging upon arrival to JHH, HOPCOM will contact imaging area to confirm. When Lifeline clinical team is en route to JHH with patient on board, HOPCOM will provide updated ETA to the NCCU charge nurse, the Lifeline clinical lead, and the NCCU triage attending. Lifeline clinical team will consult with medical command if indicated by Lifeline clinical protocols. Lifeline clinical team will provide JHH NCCU with an updated ETA when minutes out from JHH. Arrival. Upon arrival to the NCCU, the Lifeline clinical team will notify the CCSR that the patient has arrived. The CCSR will notify the provider and nursing teams and move the patient to the appropriate bed in Epic. The Lifeline clinical team will then transition the patient to the hospital monitoring system, the hospital IV pumps. However, the patient will remain on the Lifeline ventilator while in Lifeline care. The JHH neurocare teams will visit to assess the patient and write orders. This be the primary accepting team, neurosurgery and neurology, or the NCCU team. Until orders have been entered, the patient will remain under Lifeline medical direction. Once orders have been entered, the Lifeline clinical team will transition documentation to the Epic record. Transition of care. Care will be transitioned from the Lifeline team to the NCCU team as soon as possible. If no update after 2 hours, the Lifeline clinical team will contact the Lifeline clinical lead. Lifeline clinical lead will then contact the NCCU charge nurse for an update. Once care has been transitioned, Lifeline clinical team will notify Lifeline clinical lead that care has been handed off to the NCCU. Trauma triage. Lab values to ask for when triaging a trauma patient include a complete blood count or CBC, some sort of a metabolic panel, clotting studies or coags, a serum lactate, an arterial blood gas or ABG, a troponin, a urine myoglobin, or a urinalysis. Trauma triage continued. A CBC is useful for bleeding injuries, hypoperfusion, and post-transfusion. We ask for a metabolic panel in case a patient needs IV contrast for scans, they have any pre-existing electrolyte abnormalities, renal impairment, head injuries, or any pre-existing illnesses suggesting abnormalities in liver function or metabolism. We ask for clotting studies or coags to see if there are any coagulation issues or anticoagulants, if they need to institute the MTP or mass transfusion protocol, or for a severe head injury, so a patient with a Glasgow Coma score of less than 8 or a brain pathology, also in patients greater than 60 years old. trauma triage continued. An elevated serum lactate can show evidence of tissue hypoperfusion. We may get a repeat ABG on a patient with a pulse ox of less than 90%. Serum troponins may be trended for a patient with an MI. A patient at risk for rhabdomyolysis may have a CPK or a urine myoglobin drawn. And a urinalysis may be done on a patient with hematuria or someone that has had abdominal, flank, or pelvic trauma. If the answer is yes to any of the following criteria, HOPCOM should contact the Lifeline clinical lead phone to activate a Lifeline transfusion event. Number 1, hypovolemic or hemorrhagic shock with any cause. Number 2, bleeding in pregnancy. Number 3, a GI bleed. Number 4, active bleeding in a trauma patient. Number 5, hypotension with a last hemoglobin of less than 8. Number 6, a hemoglobin of less than 7. Number 7, ECMO retrieval. Or number 8, hypotension with a systolic blood pressure of less than 90 or a MAP of less than 65 within the last hour. Inclusion criteria for a Lifeline transfusion event include number 1, hypovolemic or hemorrhagic shock. Number 2, anemia with a hemoglobin of less than 7 and a MAP of less than 65 or concern for shock. Exclusion criteria includes number 1, patients refusing blood product administration, and number 2, medic alert tags indicating objection to blood. If a patient meets activation criteria, HOPCOM will notify the clinical lead. The clinical lead will review the case and make the determination if blood should be deployed. There are 2 pathways for deployment. Number 1, rapid release, which is 2 units of PRBCs, or number 2, a custom cooler, where the clinical lead will consult with the MD on call to review a case and then decide together if the patient requires additional blood products, including FFP, cryoprecipitate, or platelets. Medical consult must be performed prior to transfusion. Labs to ask for in sepsis triage: complete blood count or CBC, C-reactive protein or CRP, procalcitonin, arterial blood gas or ABG, a CMP or comprehensive metabolic panel with liver function tests, coagulation studies or coags, and a lactate. For rule out or suspicion of sepsis, there must be infection, documented or suspected, and some of the following in these 5 categories: general variables, inflammatory variables, hemodynamic variables, organ dysfunction variables, and tissue perfusion variables. General variables include a fever of greater than 38.3 degrees Celsius, hypothermia with a core temperature of less than 36 degrees Celsius, a heart rate of greater than 90 beats per minute, tachypnea, altered mental status, significant edema or positive fluid balance, greater than 20 mL per kg over 24 hours, and hyperglycemia, a plasma glucose of greater than 140 in the absence of diabetes. Inflammatory variables include leukocytosis, a white blood cell count of greater than 12,000, leukopenia, a white blood cell count of less than 4,000, a normal white blood cell count with greater than 10% immature forms, elevated C-reactive protein or CRP, and an elevated procalcitonin. Hemodynamic variables include arterial hypotension, so a systolic blood pressure of less than 90 or a MAP of less than 70, or a systolic blood pressure decrease of greater than 40. Slide 52. Organ dysfunction variables include arterial hypoxemia, a P to F ratio of less than 300, acute oliguria, urine output of less than 0.5 mL per kg per hour for at least 2 hours despite adequate fluid resuscitation, creatinine increase of greater than 0.5, coagulation abnormalities, an INR of greater than 1.5 or an APTT greater than 60 seconds, an ileus, which is absent bowel sounds, thrombocytopenia, a platelet count less than 100,000, or hyperbilirubinemia, a plasma total bilirubin greater than 4. Tissue perfusion variables include hyperlactatemia, a lactate greater than 1, and decreased capillary refill or mottling. Knox box nitric deployment. Criteria for deployment includes triggers from triage, an FiO2 of greater than or equal to 70% and or a PEEP greater than or equal to 10. HOPCOM identifies the need for a nitric transport based off of ventilator settings, end-tidal CO2 and pulse ox, and a P to F ratio if available. If not, the team can calculate that with previous values. Specifics for leadership involvement in decision-making include contacting the clinical lead. The clinical lead will then assist to find either a super user or will contact the RT charge. Deployment of Knox-Box does not necessarily mean it will be initiated. Diabetic Ketoacidosis, or DKA, is a serious complication of diabetes that occurs when your body produces high levels of blood acids called ketones. Causes include it develops when body cannot produce enough insulin, illness, so an infection or an illness can cause the body to produce higher levels of certain hormones, such as adrenaline or cortisol, that counter the effect of insulin, or an issue with insulin therapy, missed insulin treatment, or inadequate therapy. Signs and symptoms include excessive thirst, frequent urination, nausea and vomiting, abdominal pain, weakness or fatigue, shortness of breath, fruity scented breath, and confusion. Knox-Box nitric deployment. Criteria for deployment includes triggers from triage, an FiO2 of greater than or equal to 70% and or a PEEP greater than or equal to 10. HOPCOM identifies the need for a nitric transport based off of ventilator settings, end-tidal CO2 and pulse ox, and a P to F ratio if available. If not, the team can calculate that with previous values. Specifics for leadership involvement in decision-making include contacting the clinical lead. The clinical lead will then assist to find either a super user or will contact the RT charge. Deployment of Knox-Box does not necessarily mean it will be initiated. In conclusion, labs are a crucial part of patient care. Having a basic understanding of them better helps our patients at all levels. If you have any questions regarding this presentation, please reach out to your educator. Thank you.